Good afternoon and good evening, everyone. Welcome to ZimV Institute online webcast. My name is Clara Bertram. My colleague, Dr. Emigan, is here with me today, and we are your hosts for this online webcast. We would like to inform you in advance that we will not entertain any questions during the Q&A, as this is a rebroadcast of a recorded session and not a live webcast. Thank you and do enjoy the presentations.
Welcome to ZI Live Clinical, hosted by ZimV Institute. Thank you all for joining this evening. My name is Brad Lind. I'm an education coordinator for ZimV Dental, and I will be the host for today's program. For today's program, the topic will be immediate implant loading with partial extraction therapy in the aesthetic zone using the T3 Pro implant. I'm very excited to be joined by our presenter, Dr. Amar Katranji. Before we begin, though, let me tell you a little bit about him. Dr. Katranji received his dental degree and Master of Science in Periodontics from the University of Michigan in Ann Arbor, Michigan. He is a diplomate of the American Board of Periodontology and the Dean's Faculty at the University of Michigan School of Dentistry, Department of Periodontics. Dr. Katranji has numerous publications in periodontal and implant peer-reviewed journals, as well as lectures on implant-related topics. He is a past recipient of the Ramthior Award for Excellence from the University of Michigan, the Leadership Award from the Michigan College of Dentists, and he was a finalist for the Lazara Implant Fellowship of the American Academy of Periodontology. Dr. Katranji was involved in the development of new bone grafting materials that make dental implant placement possible in more complex situations. He practices periodontics and implant dentistry in Ann Arbor and Southfield, Michigan. Dr. Katranji has two really great cases and a great presentation to share with us today, so let's welcome him now.
Thank you, Brad. I appreciate that. Can't wait to get started.
All right. I will go ahead and we will get started now.
So this is an interesting case. We have a patient who happens to be, of all things, the husband of a referring doctor's hygienist. And many years ago, he had some trauma to his anterior teeth and had to have some crowns made. Number 8 specifically had the brunt of the trauma. And over the years, he's had crowns changed. And now we've come to a point where number 8 can no longer be saved. And of course, this is quite traumatic for our patients. And we have to decide how we're going to treat these patients. What are we going to do here? Are we going to do a crown, another crown, attempt to save it a little bit longer? Are we going to do a bridge? Obviously, removables. You guys are here because you're interested in implants, and that's the best treatment for this patient. What we're going to do is we're going to take this tooth out. We're going to place an implant immediately, and we're going to try to use his crown as his temporary. That's going to be the most ideal treatment we can give this patient or any other patient. But of course, there's got to be factors that allow us to accept these patients and to create these treatment plans for them. And we'll go over some of those and specifically for this patient today. Whenever we do implant therapy, it's really important for us to have as much diagnostic aids as possible. And of course, we all have knowledge of this, and we know that imaging is important. And for us, a CT scan is critical. And when we're talking about immediacy, when we're talking about doing things like a partial extraction. What exactly is a partial extraction? Well, we're going to leave part of the tooth behind, but we have to make sure that that part is healthy enough to remain. So we need these three-dimensional images so that we can very accurately determine if a patient is a candidate for procedure or not. So here we're looking at a CT scan. We're looking at a cross-sectional. And, when we finally decide that it's a go, we take a look and we have in our minds a procedure that's going to be successful for our patient. In this case, we can see that we have enough bone apical to the root. We do have a periapical radiolucency, an infection that needs to be taken care of. This patient, again, had a root canal that has to be cleaned out. We have some thickness of bone on the palatal, which is going to help us. And we also have to be aware that the nerve isn't going to be in our way. All right. So here we have day of surgery, patients anesthetized. We're going in. I typically like to use an Orban. It's a really nice instrument to kind of go around the gingival margin, very, very delicately separate those fibers from the tooth. I know there's a lot of different instrumentation, microsurgical knives. For me, as a periodontist, this is kind of like my go-to instrument whenever I start a procedure. It's very, very delicate as far as removing those fibers, and also gives you that feedback, making sure that when you remove a tooth, the tooth isn't going to be attached to the soft tissue and you're not going to tear anything. So you can see, I mean, this is a pretty normal situation that we'll have whenever we're doing an extraction, and we want to very delicately remove the crown. In this case, we're going to try to keep the crown because that's, in an ideal situation, that's going to be our temporary. So here we have popped off that crown, and you can see what's left. Kind of a hopeless restorative situation, and one that hopefully by the end of this treatment, the patient's going to be happy and is going to go home with the same crown that he came in with. Whenever we do extractions, I mean, there's this ongoing thing, atraumatic extraction, atraumatic extraction. Really, what we're doing is we're trying to remove this tooth, this root, with as little disruption to the adjacent tissue as possible. We don't want to disturb the bone if possible. Of course, we're going to have a little bit of trauma, and of course, there's going to be some changes and alterations in the tissue, but we just want to minimize that. Here, just instrumentation, utilizing a smaller elevator, slowly pushing that around. You'll see my fingers in and out, helping and assist and guide my instruments. I'm always using my fingers and my hands in the surgery. I know it's something you got to be extra careful with. You obviously don't want to cut yourself, but it does help guide you and guide the instrument so that the instrument doesn't slip. You don't have extra pressure or undue force positioned on soft tissue or bone, and you'll get that feedback, that tactile feedback that's so necessary to know what we're doing. So very carefully, kind of figuring out your mode of attack here. Many times we're going to push the tooth. We're going to push our instruments apically. We're going to push up towards the bone so that the root pops out. And in some cases, that's what we're going to be doing. All right. So here what we have is, we've moved the tooth a little bit. We're getting a sense for what the root's going to do. And since we're doing a partial extraction, what I like to do is I like to use a longer burr, and I go right in as if I'm going down the canal, and I'm going in like you're removing the nerve, going down deep down the center of the tooth, and then slowly going distal and mesial to separate the tooth, cut it in half, and allow for enough space for when you do put some pressure on that root, it fractures inward, but we're maintaining the outer shell. So remember, when we're doing a partial extraction, really what we're trying to do is maintain a small sliver of tooth facially against the bone. So that way we can preserve the bone, the fibers, all of the soft tissue that come with that are being held up by those fibers. That's what we're trying to hold on to. And in many cases, instead of doing these larger grafts with membranes, we're able to hold on to things naturally by holding on to a shell of the tooth against the facial plate. But in order to do that, of course, you have to make sure that you remove the rest of the tooth, and you got to do that carefully. Here you can see my thumb pushed up against the facial plate. I'm slowly trying to elevate from the palatal. I don't feel enough movement, so again, I'm going to go in with my instrument, with my burr. I like these long burrs. Again, you have to have a nice armamentarium of long burrs when you're doing these procedures, because the longer the root, the more important it is for you to get to the base of that, sever it and cut it off, and make sure that you're not putting undue stress onto the bone when you're elevating. And also, you want to make sure that you cut this properly so you can keep the part of the tooth in the socket that you want to keep in there. So here you can see I've actually made another cut. So I'm also dividing this into three parts, really. The part that's going to remain, and then the two palatal parts. You're going to see them pop off here one by one. That first piece got sucked up right into the suction, and here I am elevating that last piece. And what I like about this, again, is you're able to remove this relatively quickly. It's definitely going to take you longer. This is way longer than just taking the tooth out. But what it's going to do is going to give you and provide you with an aesthetic result that's really worth it. It's worthwhile. You can see that sponge is back there as well. We always see the sponge whenever you see our surgeries. And that's just to protect the back of the throat, make sure nothing goes to the back. It works as a really nice throat pack. There are other options as well. When you look at this, you want to make sure that you're not leaving behind a big thick piece. It's important to also take x-rays throughout to verify that you've removed. I will show you an x-ray where I hadn't removed the whole piece, and then I decided to go back and remove more. But the visualization of this, not just clinically, but also radiographically, is pretty important. So here we're using just a nice round burr. I like to use these diamond rounds to go in and start to shave down more and more of this root. There are some instruments that you can purchase that help provide protection of the gingival margin. I have everything. I have basically all the toys. Sometimes you just enjoy using the basics. Sometimes it's just faster. And then you don't necessarily need all the instruments that come with the PET kits. Like I said, you're going to see me do it this way, and I think it works pretty well. So here we have our surgical guide, and our surgical guide is going to allow us to place the implant, and we're going to use a nice, one of the new T3 Pro implants. And really what's nice about these T3 Pro implants is it gives you that primary stability that you need for these cases. If you're going to do a case and you don't have that apical engagement, especially when you have the long roots, you're just not going to get that comfort, that primary stability that's necessary to do these immediate load cases. And just like any other surgical kit, guided kit, you need to make sure that you're aware of how you're supposed to progress down the burr, the drill guides. Me personally, I like to under prep, and I know that many people do, especially when you're doing immediate cases. So, sometimes not going to the widest depth is a good idea, and it's going to allow you to engage the bone a lot better. And what I recommend, and you'll see me talk about surgical guides a lot. My thing right now is almost all of my surgeries are going to be guided. And the reason why is there's no more guessing. There's no more wondering if it's going to be in the right position. Is it prosthetically viable? It's going to give you a very good advantage. It's going to give you the opportunity to do the case prior to surgery, go into surgery with that confidence that's necessary to do these types of cases. And really, there's nothing like having a surgical guide that's pre-planned and allows you to feel really comfortable when you go in. I still check. I mean, you can tell what I did there. I took the surgical guide. I have what I call my blue instrument, but there's a lot of different instruments out there. And I check my osteotomy. I'm still checking, even though it's guided, even though I have that confidence, I still want to check and double check. And it's important for you to know how to do these cases without a guide before you start doing it guided, because the day that the guide doesn't work, for whatever reason, something changes, let's say during processing, post-processing, something happens. It could be just error. A lot of times we can make mistakes. We want to minimize those, but you have to feel comfortable doing these things freehand as well. But with that said, again, do them guided when you feel like a case would benefit from having a surgical guide. So again, here I am just using my instrument, checking, making sure that the walls of the osteotomy are solid. You want to make sure that you're not into the nasopalatine nerve. You want to make sure that you're not going out the facial or the palatal. and just having that tactile sensation. You'll see me go in and out, verifying the location of the crest of the bone as far as where I'm going to position the coronal portion of my implant. So many times we feel like we've removed all the root and we're ready to move forward, but then we take an x-ray and it looks like this. So it's important for us to take these x-rays and continue on and making sure that we've removed the whole root and then continue on with surgery. If there's any part of the root remaining, we need to go back and remove it so that we can have an acceptable outcome without any chance for infection. So in this case, we went back and we cleaned. We removed more and more of the root, making sure that we're comfortable with what was remaining. And again, just going in there, scratching up the buccal, making sure that you feel all the bits and pieces, and verifying that it's been removed. So here we're looking again, and we can see now that we're in a situation where the socket is clean. We have left just a small amount of residual root against the buccal plate, the facial plate, and we're happy with where the osteotomy is. So it's important even during surgery. You might have multiple things happening. You might have to go back in and remove part of the tooth that you felt like you'd gotten rid of. With the partial extraction, that part really adds time. And it's important to feel comfortable to, say, you know what, it's not worth doing it. Let me do something else if you don't feel like you can get the whole thing out. So what are we doing now? Now we're placing a drill to kind of preserve the position of the implant, and we're going to fill the gap between the implant and that remaining root shield. So I'm using PRF with my bone material. It does a really good job of solidifying the bone together, allowing it to pack really nicely and not let it go all over the place. So if you're not using PRF, whether you think it allows for better healing or not, what really is nice about it is it allows for the ease of material. And now that we've put that bone material in and around the osteotomy, what that's going to do, it's going to allow the threads at the apex to be completely surrounded by graft. Otherwise, if you do this afterwards, what occurs is the difficulty of placing the bone around the implant shows itself. And now you're really trying and struggling to get that bone in and around the implant. So do this before, and you'll find that you're going to get a much better graft. And this is the T3 Pro. We got a nice long T3 Pro that has that really nice apical design that's going to engage that bone that's remaining, that native bone, and that's going to give us a wonderful stable implant for us to then put a temporary on top of. And again, especially when you have a socket, what happens is that palatal bone, that palatal plate is much stronger than the air and the facial plate. And what that implant wants to do, it wants to drive facially, it wants to get pushed facially. So having a guide helps prevent that movement. And, if, people who've done a lot of implants feel comfortable doing it, and, there are ways of prepping the bone, prepping the palatal plate a little bit more so that you don't get pushed out quite as much. But when you're doing these cases and you have a guide, oh gosh, nothing is easier than placing the implant through that guide. So here we have again, the position of the implant is exactly where we want it. We're going to take that mount off. This is going to give us a really nice location so that when we do our temporization, when we have our temporary abutment and our crown, we're not so much worried about doing something that's going to go out the facial. This is going to be a screw retained temporary. We're going to be able to utilize the patient's crown even easier because we're going to place the access hole, the access opening on that facial. So here again, you can see the implant's position where we want it. We have a nice bone fill. The bone graft that we had placed has now pushed up against the implant all the way down the apical threads. And we're going to be in a position now to start our prosthetic conversion. So very clean. I mean, a lot of times people ask, how long is this going to take? Well, the surgery part really doesn't take that long. A lot of times it's the prosthetic part. So taking the tooth out, being very careful, being aware, that's going to be the most important. So here you can see me just kind of torquing, making sure that I like the torque values of the implant, and I'm happy with that torque value. So we like this. We like making sure that our torque is exactly beyond a certain thing. I mean, everybody has their own comfort level. Typically, when I'm doing these things, I want to be around 25 to 30. I mean, it seems like a little bit low, but my hand torque when I go to place my final abutment screw is not going to exceed that. And as long as I have proper engagement, I'm going to be okay. So I'm happy here. I'm happy with my engagement. I'm happy with my torque values. And I feel like this is now something that's going to last the patient through the temporization process when the implant is weak. And then once the implant is strong, you're going to have the patient will be ready for their final restoration. And again, as a referral-based practice, this was going to go to the prosthodontist that referred or the general dentist that referred, and they will do the final crown. You can also see there's like a little gingival hue. And as a periodontist, a lot of times we have to deal with those cases. Why is that happening? Of course, that's probably for another topic. Those margins sometimes get really close, and we tend to see some of that inflammation around the gingival margins of crowns in some of these multiple crown cases. And again, this patient recently had a new set of teeth placed, so there's a little bit of inflammation associated with that. So here I am placing a mount on top of the implant. And now I'm going to place bone again in and around the coronal aspect. So the first bit of bone was placed to really engage the apices, the threads below the gingival margin in the bone. And this is going to allow me now to place bone above the implant and maximize not just the bone volume, but some soft tissue volume as well. So a lot of times this bone is holding space and will actually get filled in with fibroblastic activity and eventually some soft tissue. So you don't have to overpack these cases either. What you really want to do is you want to make sure that the packing is strong enough and dense enough, but you don't want to overpack. You don't want material going into the soft tissue and going all over the place either. So we have different ways of doing that with different packers. My recommendation is to have multiple packers. Don't just have one bone packer, because honestly, in any surgery, you might see me use, 3 different bone packing sizes. And it's just really convenient to have various bone packing dimensions, long ones, short ones, and of course, various widths. So here I am now going to place my abutment. This is a temporary abutment. It's almost like a peak type abutment. What's nice about these, again, is it will allow you to get a little bit of bonding. And these also come with a little adjustments of the angulation. And with these cases, many times you're able to plan them, and you're planning them with real guide in this case. And before we even did this implant, when we planned this implant, we had already known that we were going to use a angled abutment. And that angled abutment was ordered directly, specifically for this case, and we're able to use that for this case. I decided to place this implant a little bit deeper. I do change constantly, even with planned cases, to make sure that I'm comfortable with the final marginal placement of the implant. I do, even when I do place a guided implant, I like to go a little bit deeper. I like to have that freedom with my initial drills so that I can get some, I can change my position depending on what I see when I'm finished placing the implant. So sometimes I'll actually sink the implant another millimeter or so, but I need that millimeter from the time I drilled. I can't decide later that I need another millimeter of depth. So even when you're doing guided surgery, give yourself that flexibility. Use an extra drill. Use something that's going to go a little bit deeper, but don't over widen your osteotomy, because then you're not going to get that primary stability. So here you can see I like the position of the implant. Here I'm using an angled temporary abutment, and everything now is going according to plan, according to the real guide plan that we had previously. So Now you can see the patient is, slowly awakening, because we do have a patient who's sedated. A lot of times we'll start to wake them up a little bit after the implant placement. They're also going to be helpful when we're doing our occlusion. We want to make sure that the occlusion is right. So we need the patient to wake up a little bit and make sure that we're going to have a tooth that's not going to get a lot of initial or any sort of contact. So another big part of this is when you're doing these cases, make sure that the occlusion is accounted for. You're going to tell your patient that you're going to have a tooth that's slightly flared. It's not going to look exactly like it did when you first walked in, but it's going to look pretty close. You might actually have it, flared out a little bit. You might have it shorter a little bit. It just has to work for the patient for those 3 months so that they don't have any sort of premature loading. So during this time, what we're doing is we're taking that crown and we're actually hollowing it out. We're removing the inside portion of it, and we're actually also removing the palatal portion so that we can have access. When we pick this up, we're going to be able to make this a screw retained. So there is a period of time where while you're finishing up, you're actually working on the crown behind the patient or in another room. I typically do this behind the patient, so that way I can go in and out, check it, and make sure that I like the position of the crown. I've seen some people kind of allocate this to their assistants. At this point, it's just me who does it, and I feel more comfortable adjusting that crown in my own hands. But now you can see, even just putting it on there, I feel like we're pretty close. It's going to look pretty good. We like the positioning of it overall. It's not, again, we're not getting 100% exact position, but we're pretty close. We want to make sure that it's not rubbing against anything. It's not going too deep into the soft tissue. We want to make sure that we're happy with the general location of this temp. And again, what's nice about this is, geez, this looks exactly like the way he came in. And that's what the patients want. They want to look and feel almost identical to the day that to the time that they walked in the morning. And so this is going to be very close to where they were. And I would say it's important for you to give them expectations. You don't want to over promise. Again, the tooth is not going to be exactly the same position. And then sometimes these things shatter, man. A lot of times this, I'll take these and I'll start working on them. And as it gets thinner and thinner, especially if it's porcelain, all of a sudden everything shatters and just completely just kind of destroyed in your hands. One of the things that you can do is you can take a suck down prior to this and use a suck down as your temporary. You just flow, you put this over the abutment, you put a suck down over the abutment that had the crown beforehand, and then you fill it in, and then you just you make a crown that way. So there are many different ways of doing it. I find that this is kind of the best and easiest. You already have a tooth that works. The patient's happy with the aesthetics. And in many cases, patients they look identical. They really do. And for a temporary to be convenient, to be attached to the implant, you don't have to worry about, a flipper. You don't have to worry about an Essex appliance. Nothing's coming in and out of their mouth. And also what's really nice about these, and as a periodontist, this is something that we always look forward to, is what it looks like at the end. The soft tissue really looks great. The bone really looks great. And this is what we're trying to give the patients, is a really nice foundation to build off of. And they're going to have this hopefully the rest of their life. We know that there's a lot of studies that show the thickness of the soft tissue and the bone around the implant really does have an impact to the longevity of the implant. And in a way that's going to be healthy and accommodating for the patient in the long run. So doing these things, even though it takes a little bit longer during surgery, has a massive impact for this patient in the long run. So we want to do these things. And here you can see, we're even, already we're in a screw retained position. We have that nice angled abutment that we knew was going to be angled beforehand because of our planning. And we're having a nice screw retained a temporary for the patient, so we don't have to worry about any cement or anything getting inside the surgical site and causing localized inflammation or infection. And we're just, kind of teasing it in, making sure that we like ultimately where it is. There's that old saying, the enemy of good is better. You also want to be very cognizant of that, because when you're doing these cases, perfection is important for for prosthodontists, let's say when they're going down the line trying to make things, beautiful with the final, but for the temporary, I'm more concerned about the bone, the soft tissue, and the implant, and giving them a really nice temporary, but it doesn't have to be absolutely perfect. I mean, a lot of times these cases are coming in, and you'll see the second case that we're going to show. The patient had a bonded tooth to the adjacent teeth, and it just didn't look great. We were able to give her something. So here we're going to give this guy a really nice temporary, and we've seen him back since then, and of course he's been very, very happy because of the end result. So here we're just checking and making sure we have good access. You want to make sure when you pick these up, when you put your flowable or whatever you're using your chair side, that you're not going to go down that channel, because you have to be able to unscrew this. And if you have material in there, it's a headache to remove. So putting something in the screw access hole does help alleviate that, prevent things from going in. And many times, you put a little bit of flowable to pick up against that peak temp. And what you're going to find is you're going to be able to pick up the abutment and the crown and everything in one fell swoop, and then you fix it outside the mouth. And when you deliver it, you're really going to have a nice temporary and a happy patient. And again, this patient's wife happens to be a hygienist, so her eyes are on this, and she's going to be looking at this every day for the rest of her life. So you want her to be happy. You don't want her cursing your name, because you're the one who's setting up this tooth for the long run. So here we're just kind of now we're going to tease this off. We're going to unscrew this abutment, and the abutment's going to be bonded to the crown. So now the work, most of the work is finished. Now we have to do the final touch up, and the patient just sits there and is nice and relaxed while we're doing this in the background, putting in more flowable, making it nice and smooth, creating a nice profile of soft tissue so that when the patient is ready for their final restoration, it's going to look really, really good. So here we are, finishing up the temporary behind the scenes. And now we're ready to deliver this temporary for the patient. And hopefully this is going to screw in. We're going to start checking the occlusion, making sure that the patient's nice and comfortable. Again, I don't like to go too hot, I don't want to really torque this implant or this abutment in. This is a temporary. I want things to be relatively stable, but I also want them to be retrievable. So you can see I'm just kind of pushing that in, and then I'm screwing it in with some hand force. I'm making sure that I like the overall aesthetic, the appeal. If I like everything as far as positioning, there's a little bit of a flare to the distal there, but again, my goal here was to maintain the aesthetics, but really focus on the soft tissue and bone, and create a long-term solution for the patient. So very, very acceptable. It's acceptable for the patient, acceptable for the patient's wife, which of course is usually the most important thing. And we're going to be covering this that screw access hole. We don't want soft tissue and other things we don't want food debris and other things to go in there. So we're going to clean that up for him by closing it off, and then allowing this to heal for at least 3 to 4 months. Sometimes we go a little bit longer, but 3 to 4 months is typical before the patient is then going to have his final crown. So just kind of screwing this in. It's important to have very long screws, especially when you're doing temporization in the anterior. A lot of times it's hard to get around the incisal edges of everything. So we're making sure that we have a longer screwdriver like that one, something that can go in there without bumping into any of the prosthetic components. So now what we're going to do is we're going to do the final touch-up. We want to make sure that the tooth itself isn't bumping into anything. One thing that's important to note is, let's say you have an anterior tooth and you're replacing it with an implant and you do an immediate load similar to this. And let's say that we have fremitus, or we have some significant mobility on the adjacent teeth. What we don't want is that constant movement and mobility of the adjacent teeth to cause any sort of trauma or problems to the implant. And this is something that we can miss sometimes. The health of the adjacent teeth is critical to the healing potential of the actual tooth. And checking the occlusion, what we want is we want this tooth to never touch when the patient just puts their teeth together. We really want to make sure that this tooth is completely out of occlusion. So much so that we're going back and back and back and double and triple checking, because that's what's going to cause failure. If we have fremitus, the patient bites down, the teeth go out of position. Now all of a sudden, all of that load is going on that tooth. We got to really make sure that we're accounting for all of those things. So here's the occlusal portion. I mean, it's very similar to the way he was when he first came in. There are times where the palatal might actually be bulked up more than we want, so you got to be careful with that. If a patient has a very deep bite, let's say they're the type of patient that bites into the gum tissue, and you see that sometimes. You'll actually see little bite prints into the soft tissue. Well, you want to make sure that if you're placing an implant and it's palatally positioned, that the implant is safe from those bite marks. You don't want those things. You don't want the lower anteriors to push against your implant every time he bites down or when he goes to sleep, or any sort of parafunction. So it's important for us to continuously monitor the patient as well, bring them back after 1-2 weeks, make sure that there's no trauma to the area, that the crown isn't loose, and then make sure that the patient is comfortable and there's no pain. We typically don't see any pain after the first few days. If the patient complains about pain for any reason, anything, after a week or two, we want them to come in. We want to double check and triple check and make sure that something isn't happening. Implants really shouldn't be painful after the initial trauma, after the soft tissue heals or the bone heals from the initial surgery. So here we're using EPTFE, or plumber's tape, people call it. We're just using a nice little, it's antimicrobial, which is nice when we put this in. It's easier to retrieve than other things. I've seen people use PVS. I've used that in the past. It's a nice filling material. This is nice because it really does fill that void up with something, and it's going to be easily retrieved once the time comes to do the final. We're putting a little bit of flowable, something to then protect and seal that area so we don't get bacteria going in there. And then we're going to check again for the occlusion, making sure that our seal doesn't have any hyperfunction. So that's what we're going to, this is more or less where we're going to end the case. So this is how the patient ends up. As you can see, the prosthetics look very similar to the way that he came in. We do have a little bit of inflammation around where we did the surgery, which is not uncommon. Ideally, we'd like to see the soft tissue completely untouched, but as you'll see, we do preserve that soft tissue, that gingival architecture over the next few weeks. Here's a nice visual of the implant. The implant has very aggressive threads towards the apex. We got a nice long implant in there, so we're engaging a lot of that native bone that we saw in that CT scan. You can see that we're using some sort of abutment, like a temporary abutment that looks almost like it's ghosting. It's not actually missing, it's actually there. And then the bone graft and the partial extraction, if you look closely, you can see that the shell of the tooth is still there, and it's going to be preserving that thin bone that's between the teeth, and as well as the bone on the facial. So this is a very, very important part of what we're doing now, maintaining the bone and soft tissue by leaving part of that tooth behind, utilizing that socket shield or partial extraction therapy. So what does it look like after a few weeks of healing? You can see that the tissue is starting to settle down. You can see that the patient isn't exactly grinding on this. Everything is looking pretty good as far as patient compliance at home. And you can see that that soft tissue is calming down. You're seeing that the marginal tissue is honestly almost as good as you can get without doing any sort of soft tissue grafts or further bone grafting. So this is a way of preserving the soft tissue. This is a way of preserving as much as we can without doing those soft tissue grafts and those big bone grafts. And really, this is a big part of what we're doing now for our patients. And I think that, potentially this could work well in your hands as well. So you'll see that this is something that's repeatable with our next case as well. So here we have another case of trauma. So this patient was on vacation, got hit in the face, and of course now requires some sort of treatment, and it needs to happen quick. And a good referring doctor called me and said, "Hey, what do we do about this case? Is this a case where we can do an immediate load?" And when we got our diagnostics, we got our CT scan, our intraoral scan, we determined that this was a good case to attempt an immediate load case. Of course, we need an implant that's going to give us that primary stability, to give us a no doubt that we're going to get temporary on top of that implant. So here we are. The tooth was splinted into place, and the first step, of course, is to remove it. These things can be a little tricky to remove, but many times it's just a matter of getting the right instrument to pull it. But you can see the crown has completely severed off, and as we're pushing and pulling, you can see that the tooth is moving, and actually part of that soft tissue has healed on top of that crown. So you'll see movement of the soft tissue, and you want to be extra careful. Now, this is a unique case because this patient had a little bit of altered passive eruption. She had short clinical crowns on 8 and 9. And the decision was made that we're not going to deal with that yet because there's too much soft tissue irritation and inflammation. We're not sure about where the soft tissue is going to end up. So today we're just going to remove everything, clean everything out, and get the implant temporary in, try to maximize the aesthetics to the best of our ability. But our long-term plan here is yet to be determined as far as aesthetics between 8 and 9. So you can see the soft tissue is very irritated. There is some compliance issue. A lot of times these patients, they're afraid to clean. They're very, very uncomfortable with the brush touching the soft tissue. It'll bleed a lot. So, the first thing that we're doing is we're going to actually clean up any of this debris, this plaque, some tartar there. So some of this stuff has been there for a while. You can see even on the lower tissue, the lower gingiva's got a little inflammation. So, as an emergency, we'll see these cases and we'll treat them the best of our ability. Our typical treatment plan, if we have a patient who requires an implant, is to do initial therapy, periodontal therapy, get them into a nice maintenance schedule before we go in and do any sort of final therapy. So as a periodontist, my scalers are coming out. I'm going to scale and root plane where I feel like it's necessary if it's around the surgical site. But our hands are tied in this case, and we decided to move forward with a little bit of cleaning. I have all sorts of materials and things that I'll use for inflammatory tissue or inflamed tissue. In some cases we're just using traditional treatment like scaling and root planing. In some cases we'll use chemicals. I happen to use something called Hybenex, which is a nice desiccant that will really help reduce the swelling and irritation of the tissue, and that's what you're seeing here. That's just that material. Again, it's just called Hybenex. It's a desiccant. It does a really good job of killing all the bacteria, kind of prepping the area prior to going in there and doing anything permanent. So just wanted to say what that was so everybody's aware. I'm not going in there and doing this without taking care of some of the inflammation that we're seeing. And here we're just kind of cleaning it all out. You can see it's done a good job so far of reducing some of that swelling. Obviously, this isn't going to be final treatment for the patient. And again, just please remember this is kind of an emergency situation and one that hopefully we'll learn how we treat them in the office. The crown itself had come off pretty easily. There's still a root inside. And our goal, again, is to do some sort of maintenance of the aesthetics, the soft tissue and the bone. And I had talked a little bit about, are we always doing the partial extraction? And the answer to the question is obviously no. In a case like this, where there's quite a bit of infection around the root, the best thing to do is actually take that diseased root out and do a regular traditional graft and maximize the bone volume that way. So I just wanted to show another type of case, another way that we do these cases, utilizing almost everything else in a very similar fashion, guided surgery, but in a way that's going to be healthy and a good long-term solution for the patient. So using my scalers, I have my Gracies in there cleaning everything out. Now I'm going to remove some of that soft tissue, that irritated tissue in and around the root. I'm also going to remove those little bonded areas that were holding on the splint for the patient, and then get everything prepped for the implant. It's important to have a clean field. Another thing is I made a surgical guide, and that surgical guide did not take into consideration those little bonded areas, those little bonded circles there. So I need to remove them so that I can make sure that my guide sits all the way down. That's a critical component of any sort of guided surgery, is that we have things seated all the way down, and you have to double and triple check and confirm. And knowing preoperatively that we have those little buttons on there, I knew that those needed to come off before the surgery could begin. So here you're just seeing me remove them, pretty quickly, and allowing the area to kind of conform to what we had for our surgical guide. And again, you can see that sponge. I like to bring up, using some sort of throat pack, something to protect the patient, especially when you're using sedation, that nothing goes in and deep inside. The first thing you saw me do there is squeeze the buccal and the palatal plate. You can see my thumb and my finger are holding those to make sure that I feel what's going on at all times when I'm placing any sort of pressure on that root. So now that I'm putting pressure on that root, it's going to want to go facial most likely, because that's usually the softer, weaker bone, and you don't want that to fracture. So holding it, preventing it from fracturing, is usually a good idea. So here I just wanted to show the root and the differences between when we do partial extraction and when we don't. When you have a diseased root and you can see that there's an infection on the root, and that's going to be something that's not what you want to maintain. You don't want to leave that behind. So typically we take these out and do a traditional therapy when we have situations like this. So now we're just going in there and cleaning out the socket. You've probably seen this probably numerous times. It's really important to get that as clean as possible. And if you're going to do any sort of elevation, I like to use this spoon curette to do a little bit of elevation of that facial tissue, so that when I graft, I have a little bit more room for that bone material on the facial. Now we have our surgical guide in place. And as you've seen before, the process of creating the osteotomy is simplified now, because we're just following a set of drill protocols, but we're not worried so much about getting pushed out from that palatal plate. That palatal plate, if you don't have a surgical guide, remember it needs to be addressed during your final prepping of the osteotomy. You want to make sure it's wide enough to allow for the implant to go in, and you also want to make sure that it's tight enough to hold and maintain your implant. So it can be a tricky thing, and you just have to be aware that that's going on while you're placing the implant, that it's going to want to get pushed out. So here we're just doing the same thing as we saw earlier, using the protocol to slowly create an osteotomy, get to depth, and making sure that we're comfortable with where that implant's going to end up. So we just go through the guides, go through the drilling protocol that's done with this Biomet Navigator kit. What's nice about these is you can buy these cylinders and print out these guides in-house and make sure that you're doing all this stuff from start to finish. Again, I use RealGuide as my software of choice, and that allows me to use for just about any implant system. You can design the position of the implant, you can design just about anything and get a really good result, a treatment protocol within your office, especially if you have 3D guides, if you have a 3D printer. That 3D printer can be used to make your guides in-house. You just need those cylinders, and you need to follow your Navigator kit or whichever kit you're using to place your implant. So sometimes you come across very dense bone on the palate, and especially if you're positioning your implant so far palatal, sometimes it's important to go back, take a step back, and do a pilot drill, something that's going to give you easier access into that palatal bone. So that's what you saw me do there. I took a step back before I went forward to make sure that when I placed my implant, I was happy. So now we're just going through the drilling protocol again. We're going step by step, one drill at a time. We did that nice pilot hole to give us access, easier access into that palatal bone. We're going to go in and out. You want to do that pumping motion to make sure that you're not overheating the bone. One of the things you may notice, some of the guides, they don't have easy access for irrigation. So putting a few holes in and around your sleeve will help alleviate some of that, so that you can get some of your irrigation through the guide into the socket, into the area where you're trying to drill. But when you're not sure, you always want to make sure that you're going in, you're doing a nice pumping motion. You don't want to just force it through some really dense bone, because you're just going to overheat that bone. And what's nice is also you have really, really sharp cutting threads on your drills. And that's also going to make sure that you're not going to overheat too much, because it's going to go through that bone real quick. So again, going through 1, 2, 3 through the drilling protocol. And, a lot of times you tell people, when you have all of this done, when you're telling your patients, the surgery, the actual placing of the implant isn't one of the longer parts of the procedure. That actually happens relatively quickly. So we want to make sure that we're already ahead of the game when we're going into surgery with these guides. So guides. I know I talk about guides a lot, but I really feel strongly about utilizing all this new technologies that we have, and bringing them to your office. Make sure that you're using this stuff. If you have a CT scan, you have an intraoral scan, you're really not that far away from buying the right software and making these guides in-house. And almost all of your surgeries can be guided surgeries at that point. And for a very little cost. It's not going to be that expensive if sometimes that's what people are concerned with. A few cents on your resins per surgical guide in the long run makes things a lot easier. And you'll be happy that you did, because your prosthetics are going to be better, patient satisfaction is going to be higher, and you're going to avoid a lot of complications. So once we're happy with the final position, once we're happy with the osteotomy, the next step always is then to, place the implant, put some bone material in and around the implant, and then work on the temporary. So now we're ready to place the implant. Again, we're using those nice aggressive threads of the T3 Pro implant. We're going in with our handpiece first, making sure that we're getting proper positioning with the initial, with the handpiece. We always start with the handpiece. It torques out usually, and then we go in with our wrench. So this is a nice way of maximizing your planning and your placement by using something that's going to go into the bone aggressively and then torque out. So here we have it torquing out right at the end there, and we're happy with the position. We're going to then remove the mount. That mount, if you have multiple implants, sometimes you can leave them in to kind of hold your surgical guide for the next implant. But here, just single implant, we're going to remove the mount. And a lot of times the mount just pops right off. Sometimes you need to do a little wiggle on it. So you can see me trying to wiggle it out. You don't want to put too much wiggle force on it. Obviously, you don't want to, reposition the implant or cause any sort of movement to the implant while you're removing it. But for the most part, a nice little wiggle there is going to get it out. Here you can see me using the torque wrench, for any sort of small manipulations, grabbing the mount with some rongeurs, getting it out, and then taking out the surgical guide. So now the implant is in. We like the position of the implant. And the next part of this is to finalize the surgery by doing the bone grafting. In a case like this, I do like to use a membrane. I like something that's going to preserve the facial aspect of the bone graft. So we're going to place some bone, we're going to place a membrane, and then we're going to use a temporary to kind of top off that site, that surgical site. In some cases, we're actually using, the patient's own tooth, just like today, we're going to use the patient's tooth again. And again, sometimes we'll use like a flipper or something else as a temporary. But of course, immediacy is important for these cases to preserve as much of that soft tissue and bone as we've discussed. And so we are going to opt again for an immediate implant. We're happy with the torque values. Again, the T3 Pro has a wonderful torque value that you can get out of it. And I think that's what you want, is you want to pick an implant system or an implant that has an aggressive thread design towards the apex. And I will tell you, there's different types of implants that do a very good job with immediate load. My feeling is that if you're going to have native bone, a lot of native bone, then something that has a tapered aspect to it, you're going to get pretty much you're going to get primary stability from it if you have a lot of bone. When you're doing immediates, when you're doing extractions, the extractions typically require a much more aggressive thread design like the T3 Pro. And I think they did a great job as far as getting that apex to stabilize in the that small amount of bone after an extraction. So here again, we have the abutment that we're going to use. Now, this is a little bit of a different abutment than we used before. This is going to allow us to do an angle channel. It's an angle channel abutment, so that we're allowed to in some cases create a screw retained crown, even though the implant position isn't necessarily ideally set for that. So what we're going to do is we're going to use this type of abutment. It's a little bit different again than the one we had before, but it does a really good job of allowing us to get those screw retained temporaries that are so necessary when we're doing immediate load cases. So this goes in, and what we're going to do is right now we're using that crown, we're adjusting it, we're hollowing it out, we're making sure that it's going to fit over the temporary abutment. And that has to go very carefully. You want to make sure that you don't cause anything to shatter, because that temporary is going to be the best temporary for the patient. We also have to flare this out a little bit because there's a little bit of flare to the position of the implant. And then also we don't want the patient to bite on this at all. Just like we talked about earlier, any sort of hyperfunction, hyperocclusion, that's going to cause problems for the patient, for the implant. And we just want to avoid all of that during this time. So now that the area is nice and dry and we feel comfortable, we're going to take the patient's crown. You can see that we've removed everything, including the palatal portion, but we've kept the facial. So this is going to just basically sit on top of that temporary abutment that we're going to use. You can see it's flared, and I know this is, again, not ideal, but we're going to create something for the patient. And it's going to be a lot better than any flipper Essex appliance that they can wear. And it's going to be completely out of occlusion. And I tell patients this, and like we've mentioned before, we don't want that thing to be in any sort of a function when the patient bites down. And we want that soft tissue to kind of heal up a little bit. Checking the occlusion, making sure that the patient isn't biting hard on anything. And then we're going to finalize any of the aesthetics outside, cleaning up the temporary outside and making sure it's nice and smooth. This is usually picked up relatively quickly. She had a diastema before, so we're going to maintain that diastema. Sometimes you get caught into trying to fix things that were there before. There's no reason to try to fix a diastema, especially if it was there before. Now we're going to remove the picked up abutment and the crown. And you'll see that once it comes out, it usually comes out in one piece. If it doesn't come out in one piece, you just have to pick it up again. And again, we mentioned this earlier, you really need to have those long screwdrivers. Those long screwdrivers are very useful when you're doing these cases, because your prosthetics, your crown, is going to get in the way of your screw access hole of your short driver. So you want to make sure you have a longer driver that doesn't get bumped out by the prosthetics. So here we finally got it out, and we're going to start to adjust it. So what you want to do is you want to really make sure that you have a nice clean margin around your temporary. You don't want to have flash. You don't want to have bulkiness. You want to make sure that you have, for the most part, a very smooth temporary for the soft tissue. The temporary, then you want to make sure that it's checked. You check it inside, make sure that the implant or the abutment fits the implant appropriately. Sometimes you come back and you might actually see these rotated, and you just got to kind of start over again. And you're getting a general idea of the aesthetics here. Now, again, remember, this patient has some altered passive eruption, has some some short clinical crowns. We also had some very thick tissue, inflamed tissue. So the aesthetics here are going to come over a period of time with a much larger prosthetic treatment plan. But right now we're just trying to maintain and create a nice situation for the patient to be temporized in. The next step for us is the bone grafting. In order to bone graft, you want to make sure that nothing is going into the implant. So we have these mounts, or you have other things that you can place into the implant and make sure that things don't go in. We're also going to use a membrane. And if you remembered, I used my little spoon curette to flap the tissue to kind of create a little bit of space. So here you're seeing that same spoon curette slowly position the membrane into position on the facial. And you can see it's not easy. It doesn't take, sometimes it takes multiple attempts to get it into the spot. And you'll see me just kind of slowly tease it into the spot that I like. I want to make sure that it's over the bone. It's creating a nice pouch for that bone material that we're going to use in a second. And therefore, when we get our graft resolution over a period of time, we'll have a nice facial bulkiness around the implant. So you'll see it slowly work its way in. Sometimes it takes a little bit longer than others, but now we have a nice collagen membrane pushed up against that tissue. I'm going to put something to cover my implant, making sure that the little granules don't go in. And then I'm going to check to see that my bone packer can fit around the implant where I'm going to place the bone material. As we discussed before, we're going to pack this with the bone, and that bone is going to be hydrated, saturated in that PRF. We use platelet-rich fibrin for almost every single surgery we do. It's important for you to feel comfortable with any protocol, and for us, this is something that we feel very comfortable with. Placing the bone, packing it in. My big head's in the way there, but you can see that I'm definitely placing that bone in and around that implant, and then pushing out that facial tissue as well, pushed up against that membrane, and getting a nice cohesive graft around that socket. And you see I'm putting a lot more than I'd had to place from my previous procedure afterwards, because it had a big infection, big loss of bone. So we want to make sure that we get as much of that as possible back. We're going to lose some. So you're not going to get 100% of your bone material, but you're going to get a lot of it if you do it properly. And a lot of times you're able to get a nice solid buccal plate over that implant after just a few short months. So once that's in, we feel more comfortable. I like to use my finger again to push against that tissue to really firm everything up. I like to make sure constantly that I'm packing it in. I don't want my bone granules to be loosely packed. I want them to be relatively packed densely in and around the implant. And then any sort of void that I feel, I'm going to push my material in and until I feel comfortable. If I overpack, what I'll do is I'll just remove a little bit of the extra material. I don't necessarily feel like overpacking is as big of a problem as if I underpacked. So if I overpacked, a lot of times you'll see a little bit of extra residue that you'll have to remove at the end of the surgery. That doesn't take very long to remove. You don't want your bone to be in between your flap margins, but again, here, since it's an immediate case, we already have an opening where the socket is. And we're just packing, we're making sure that we're constantly reassessing and making sure that we feel good about where that bone ended up. We also want to make sure that there's no voids on the palatal, so we double and triple check that. And if there is a void on that palatal, just kind of scooch some of that bone around, and sure enough, you'll get that void filled. So here you can see the implant is completely packed. There's a dense bone particulate around. I like to use the corticocancellous bone, the Puros corticocancellous for these cases. In some cases, I'll use the mineralized bone material that they have. If I have a big defect, the one that doesn't have any like solid bony support, I definitely will use the cortical cancellous mixture that comes from Puros. So here I am just screwing it in, double checking. I like everything. We do have that extra tissue, so some of that's going to be trimmed away. And then we're going to check the occlusion, making sure, again, nothing is hitting. I don't want anything hitting from the adjacent teeth, and I don't want anything hitting from the opposing dentition as well. So we're just cleaning everything and slowly getting the patient back into a comfortable scenario with their aesthetics and function. We're going to put a couple stitches on either side. You can use simple interrupted. You can do vertical mattress. In a case like this, again, the soft tissue is so bulbous, you're just trying to put them back and make sure that the tissue over time heals. So this is the patient when they're done. They go home and we have a nice solid implant with bone around it, and we feel comfortable that we're giving the patient a good long-term solution right from the start. So thank you very much. I appreciate your attention, and I look forward to answering any of your questions. Thank you very much.
Great presentation as always, Dr. Katranji. Thank you so much for sharing. We have some great questions. Absolutely. We have some great questions from the audience. Let's get to those. First, we have, would you create a pseudo switch platform with the thinning of the temporary's gingival neck?
I missed that first part of what the question was asking, but typically when we're doing these procedures, we're trying to select an implant that has some sort of platform switching because it does allow for more of that bone and soft tissue to interact around the implant and thicken and have a nice thick barrier, especially at the coronal aspect of the implant going up into the prostheses. So you do want to select a good implant. You want to make sure that the implant has aggressive threads. You really want to make sure that the implant, when we go in, really takes a good bite out of that bone. Apically, the implant needs specifically like aggressive threads. So when I'm looking at the T3 Pro, for instance, I like it because when I'm going into that socket, remember we talked about the sockets not having a lot of bone or as much bone as maybe a site that's been grafted or that's been missing for a while, and you're placing an implant into native bone. What's great about this implant is that maybe that last 2-3 millimeters really engages and gives you that primary stability that you might not get with some other implants. And there are some of these other implant systems out there that do that, but what's nice about this is it's really, really tight and compact to that osteotomy that you make. They do a good job of showing you the differences between this implant system and some other implant systems. I've personally used other implant systems in the past, and I stopped using them because the way that it would engage the bone wasn't necessarily the way that you wanted. You don't want the threads to be so sharp and so aggressive that they're outside of where your osteotomy is, and you also want it to engage the osteotomy properly. And so what I would find is I would come back to these sites and I'd have my threads kind of cutting through the bone and into the soft tissue. And so you're not going to get that issue here because the way that those drills are designed is that they're made specifically for engagement of these threads, allowing for the bone to maintain itself and also for the blood supply to stay around the bone and the soft tissue. So you need to pick implant systems that respect the soft tissue at the apex and at the prosthetic connection. I think that's maybe what he was asking.
Okay, great. Thank you so much. Next we have, do you find that some of the bone particulate gets into the implant screw channel?
So you saw what I did there. When I placed the implant and I was grafting around the implant, I used a mount. I used something that went into the implant and basically plugged the implant channel. So when I'm pushing my implant around the implant, and when I'm pushing my bone graft around the implant, there's something preventing that mount that I put on there prevents the particulate from going inside the channel. So yes, if you don't do that, maybe put a cover screw on, pack it around, and then take the cover screw off when you're done, and then place your abutment.
Okay, great, thank you. Next we have, would you do an immediate implant loading on a premolar?
Yeah, so I've actually placed, I've done an immediate almost in every single position. And it comes down to planning. It really does come down to looking at the patient's occlusion, looking at the aesthetics, and then deciding whether it's worthwhile. If you have a situation, let's say you have a case where somebody has a primary or a deciduous tooth that's been retained. You know, sometimes you get a lot of bone there. Sometimes you don't. Sometimes the bone isn't the best quality, but let's pretend you have really good quality bone around that. You know, at that point, it really makes a lot of sense to do an immediate case because you have really good bone and you'll have really good soft tissue preserved from that deciduous tooth. So it premolars, molars, I've really done them in every position, but it always comes down to whether I can protect the occlusion on the implant, making sure that the implant isn't in some sort of hyperfunction. You want to make sure also that it's not a bruxer, somebody who comes and just can't, you can't protect the implant. And then also heavy smokers. I really don't like doing cases like this in heavy smokers who really they really do create a problem for all sorts of cases, to be honest.
Okay, thank you. Next we have, what are the most important factors when treatment planning?
So I like to look at a few things. One is the soft tissue and the hard tissue. You want to make sure that the soft tissue is in a position that you don't necessarily need to graft. You can do soft tissue grafting with these cases, but it just adds a level of complexity that might not be what you want to take on a case-to-case basis. So if you have really thick tissue and you have really thick bone, those are usually good cases. Now, in these two cases, the first case we had good bone at the apex, so we knew that we were going to engage and have a good shot at primary stability. The second case, it was a little bit more difficult as far as the facial aspect, so we knew we had to reconstruct the facial. We had soft tissue. We did have an altered passive eruption case there, so there's still more work to be done there. But again, we had a short root with very good bone at the apex of that root. So those cases are usually good cases. And the way that I like to treatment plan these cases is I like to get a CT scan, and that CT scan allows me to look at what kind of bone do I have at the apex. And if I'm going to do a partial extraction, it's going to allow me to look at what kind of bone I have on the facial. If I have good bone and I have a healthy tooth structure pressed up against the facial, I'm going to attempt my partial extraction therapy and I'm going to attempt an immediate placement. When I place my implant, if I get really good stability, so again, we're using an implant like the T3 Pro, I get really good stability, then I'm going to go forward and I'm going to attempt immediate loading. Now let's pretend I go in and I place that implant. I'm just not happy with that primary stability. So what do? Well, we want to make sure that we're grafting, we're making sure that the bone and the soft tissue is respected. And the way you do that is you pick a good abutment. One abutment that we use quite a bit right now is the new Encode Emergence. And one of the nice things about that is it gives you a really beautiful emergence profile of the soft tissue, kind of lending itself to that question, that first question. You want to make sure that, you're doing a platform switch if possible, and then you also are going to maximize the bone and the soft tissue at the neck of the implant, at the neck of the restoration, and give you that emergence profile that we're trying to achieve. And if it's already built into your abutment, like it is with the Encode Emergence, you really get a nice final restoration. You're preparing yourself for a final restoration that's going to look really, really nice. And you don't have to do anything. Many cases you're just placing an abutment, and that emergence profile is actually built into the Encode abutment. So those are things that we'll typically do. I like to use RealGuide. So once I have that 3D image and I have an intraoral scan, I combine those two And what we've found is using software like the Real Guide, it gives you a lot of advantages. I mean, one of the nicest things is I can use this thing anywhere. I can use it on my phone. I can use it on my iPad. I can do it, when I'm at home with my family, and I can interact with my referring doctor, my lab. It's a really, really nice thing to have that level of communication built into software. And especially again as a specialist, that's a wonderful thing. Now I also have a 3D printer in my office, and if I can quickly, and I've timed myself in 5 to 10 minutes, I can do this from start to finish. I can put this into my software. I can plan the case, and then I can create a guide. And if I have a 3D printer, like I have a 3D printer, I can send this to my printer, and then within 40 to 50 minutes, it's printed. Just having the resins and all that stuff in house makes this very predictable and very quick. I don't necessarily have to send it out. If it is a more difficult case, like I said, I have that interaction with my lab. Again, I use 360 DigiLab. They're a local lab. I always recommend using the lab that's very, very used to the digital workflow. And what you're going to do is you're going to get a predictable result almost every single time, whether it's an extraction and you're doing an immediate, whether it's a full arch case. If you're doing a full arch case, really you should be considering guided if possible. And then these very aesthetic cases, putting these implants, multiple implants if you're doing a bridge, making sure that you have the positions aligned with your restoration before you go into surgery just makes a lot of sense. So, the ease of use with these softwares, again, the Real Guide just makes it real easy for us. And all the doctors, and we have multiple offices, every doctor's using it now, and we're doing, almost every one of our implant cases, we're trying to push for a surgical guide. So that's how we plan these cases, whether it's an aesthetic case, a straightforward case, an immediate load case. All of these things are planned with the prosthetics in mind, and then the anatomy always in consideration.
Okay, great. Thank you very much. Next question is actually it's three into one, so bear with me, okay?
Sure.
For partial extraction, do you only use the middle third of the root and remove the apical third of the root? How?
No, I'm sorry. Go ahead.
Do you want to answer that part first, and then?
Yeah. So I typically do. So the apical third, unless I have a situation where I'm very comfortable removing, I'm personally very comfortable removing most of the tooth and leaving part of it behind. And if I feel like the apex is 100% clean, I'm not worried so much about leaving a part of it behind. I do root banking, meaning I'm leaving, roots in when I'm doing full arch cases. So, leaving part of the tooth behind isn't a concern as long as it's a healthy root. That's why I'm taking that X-ray in the middle of surgery and at the end of surgery just to verify that whatever I've left behind is healthy and not going to cause an infection later.
Okay, great. And the next part of that question, how thick of the root fragment is needed for PDL support?
So that's a good question. I mean, it's really difficult for us to measure like 0.5 millimeter and 1 millimeter. So, I know that there's histology that'll show that we want to leave, around 1 millimeter or less, but it's hard for us to do that. So really you have to use your own clinical judgment, clinical sense. Leaving it too thick usually is not a problem. So, if you have one that's 1.5 to 2 millimeters, it's not really going to be the end of the world as long, again, if it's healthy. But, if it's super thin, sometimes I'm not so sure that we're doing the service that we're trying to achieve, and it's just taking a lot longer. So I guess my feeling personally is err on the side of a little bit thicker than a little bit too thin.
Okay. And then the last part of the question, can you section the root in halves before using an elevator at the mesial, palatal, distal aspects to loosen the root?
Yeah, I mean that's a technique you can use if you feel comfortable. you can do it. You can section it in 3 or 4 different pieces and then start to elevate it. I will almost always just go by the tooth itself. I mean, I have some of them that just very easily will section off, and you're kind of on your way. And then sometimes we have ones that take a little bit of time. So that technique sounds good. I think that's a good technique if it works. But you'll develop your sense of what to do during surgery. So, the short answer is every case is a little different, but that technique sounds fine to me.
Okay, great. Thank you. Next, we have what size implants for these cases?
So in this case, I used a 4.1 by 13 for both. I believe both of those cases had a 13 millimeter long and the 4.1 millimeter diameter implant. Now, this was also the platform switch one, and the platform goes down to, I believe, 3.25. So the connection is a little different. Than the size of the connection is a little different than the size of the diameter of the implant. So, and that's what you want. That's what you're looking for.
Okay, thank you. Next, we have, what is the name of that yellow throat pack?
So it's funny. That's just a sponge. I believe you can find those now more and more. A lot of different companies sell them. It's just I think they call them a laryngeal sponge, and this is like a packing, like a tissue, like a throat pack that we're using. Even in the office, one time there was a shortage on sponges, and so what we did is we actually purchased some sponges ourselves and we sterilized them, and that worked as well. So this is really just absorbing saliva and all sorts of debris. So just as long as you have something sterile and the right size, you should be okay.
Okay. Can you repeat that one more time, the name of it again?
I don't want to give the wrong name, but I think it's called the laryngeal sponge.
Okay, great. Thank you. Let's see. Next we have, do you prefer 3.4 millimeter implant instead of 4.1 millimeter for the central? What about the canine?
Okay, so this is a good question. Again, it comes down to each site. The 4.1, when you're using these types of implants, I think is fine because you're using the 3.25 connection. You also want to get really good stability, and sometimes you may not get that with one of the narrower implants. Of course, you can. I'm not saying that it's not, but it's easier sometimes with a 4.1. In a canine location, again, ideally, I'd like to get something at least 4.1 millimeters in diameter. There are, for instance, the TSV implants that have a 3.7 if you're really concerned about, fitting one in. But even the 3.7 maybe in the central is okay. I probably would still venture for a 4.1 for a canine. So that's just my personal feeling. My personal opinion is if you can get to, I don't like to go too wide. Again, I don't want to go maybe to a 4.7 or 5.0 or anything along those lines. I like a 4.1 in the centrals if possible.
All right, great. Thank you.
Mm-hmm.
It looks like this is the last question. I know you touched on this briefly before, but with partial extraction therapy, how important is having a CT scan?
So CT scan to me is critical for a lot of these cases. And if you're going to up the level of complexity with a partial extraction, you're just doing yourself a favor by taking a CT scan. It's going to give you a lot of information about the root, about where you're going to be sectioning, where you're going to be, removing. And then, with immediate load, if you're going to do an immediate load, again, the CT scan is going to give you every opportunity for success. And in my opinion, it's absolutely critical.
Great. Well, that was the last question. So I want to thank you. Thank you so much, Dr. Katranji, for being here and sharing your presentation and cases with us. And I very much look forward to you sharing another case with us in the future.
Thank you, Brad. I appreciate that.
Great. Have a great night.
You too.
We thank you everyone for joining us this evening. Next week, Tuesday, the 13th of December, we do have another rebroadcast of Dr. Amal Katranji on today's topic, which is ZI Live Clinical Immediate Implant Loading with Partial Extractions Therapy in the Aesthetic Zone using the T3 Pro implant. On Wednesday, the 14th of December, we have Dr. Richard Capitan's rebroadcast of AZI Live Clinical on his topic entitled The Full Arch Handbook, a breakdown of revitalized treatment planning and executions. Do scan the QR code on the screen now for more information regarding this lecture and to register. We have put out on our screen now the Zoom QR code for ZimV Dental app. Simply point your smartphone camera to the screen and a link will pop up for you to click on to bring you to the App Store to download the app. In the app, we put our live webcast on-demand courses for you to choose from to attend. We will leave the QR code on for a little while for you to do so. Thank you once again for being with us. Till our next course, stay safe and take care.